I'm Nuala and I am a nurse and I am the Clinical Skills Manager in University College Cork, the School of Nursing and Midwifery. And this is my colleague Claire who is here with me today. So the premise of my talk today really is to report on a systematic review that I completed primarily as part of my PhD work, but also because I was interested in how simulation could be used to enhance non-technical skills, in particular situation awareness, which is the topic of my PhD. So the background in terms of my own interest is patient deterioration in a ward-based clinical situation in an acute hospital. And as a nurse, we would suggest that a lot of times it is the junior nurse in the ward who has to recognize that very first sign of deterioration and make that choice to call the team or call the medical team. And junior doctors frequently are the first people who actually respond, in our country anyway. And whilst we know there is a complex interplay of socio-cultural, contextual factors that constrain the effectiveness of early warning systems, it is without doubt that delays in the recognition of patient deterioration and the escalation of care continue. And there is a lot of work, particularly by a group in the States, Brady et al., who've done an awful lot of work around pediatric early warning scores. But generally speaking, in healthcare, there is acknowledgement that situation awareness at both an individual and a team level is viewed as an underlying cause, or one of the underlying causes of many of these failures. So just to contextualize situation awareness, it's sometimes referred to as situational awareness, but apparently that is grammatically incorrect. So I'm using the situation awareness version. According to Flynn et al., who have obviously written an awful lot in the human factors healthcare literature, situation awareness involves the continuous monitoring of the clinical situation in order to understand what is going on and what might happen next. And that's probably the most simplified version of the definition of this concept that you'll see. It is a core concept within the human factors and ergonomic research community literature, and it is gaining significant traction in patient safety research. However, it's not without its contentions. If you read the literature, situation awareness has been defined from an individual, team, and system perspectives, and some commentators like Van Decker would say, does it actually exist at all? And it can be viewed as a negative concept, as a blame concept, and promoting a culture of blame. So there's all those sort of ontological and epistemological considerations within the literature. That's just really to give you a background from where it's at. Now, I'm sure many of you would have seen this model of situation awareness, which is probably the most, well, it's definitely the most common model and common definition of SA within the healthcare literature, and actually also within the broader literature. And Mika Endsley defines situation awareness across 3 ascending levels. She defines it as the perception of the elements in the environment, the understanding of those elements, and then the projection of future states. These aren't sequential, but somebody with a higher level, say the projection of future states, has better SA than someone who is only at level 1. Now, lots of things affect RSA, including the state of the environment. Just to say, SA is a precursor to decision making. It is acknowledged, but it doesn't absolutely define this decision making or confer decision making for that matter. And the same with performance and actions. So in other words, you could have good SA but make a wrong decision, or vice versa, you could have poor SA but happened nicely to make a good decision. SA is also affected significantly by our abilities and our experience and our training. And people who are more experienced have better SA, generally speaking, and can confer SA easier in an acute situation. So my real interest is in this notion of training for situation and awareness. Then things like stress, anxiety, complexity, workload, all affect a person's capacity to attain SA. Just like the speaker this morning was talking about with the crews in the pit stops. If you're anxious, it's difficult to ground yourself. Sorry, I should have put those circles up when I was talking about them, but anyway. So the objective of our review was to appraise and summarise the evidence and determine the educational effectiveness of educational interventions on any healthcare professional's SA. And we obviously used the PRISMA and the PICO framework, and sorry if that writing is a bit small. And we searched a range of electronic databases over a 10-year period. We included any healthcare professional and any kind of educational intervention that had SA as either a targeted intervention or as a component part of a broader intervention, such as crisis resource management training. And for comparison, it was for any alternative education, normal practice, or pre-test, post-test. We included outcome measures of SA at level 3, that's behavioural change, level 4A, change in professional practice, and level 4B, benefit to patients of the adapted Kirkpatrick's hierarchy. We assessed our papers with risk of bias from the Cochrane collaboration, and we used the Medical Education Research Study Quality Instrument for quality assessment. And ultimately, we ended up with 17 papers that were randomised or quasi-randomised trials, and 22 papers which were other designs like pre-test, post-test, one-group designs, which we separated then into a meta-analysis of the randomised trials and a narrative synthesis of the other designs. Study characteristics, you can see here in the green part of the pie chart, 46% of the papers were for single disciplines, postgraduate single disciplines or experienced single disciplines, 10% undergraduate single disciplines, and remaining papers were multidisciplinary teams, or in often cases 2 to 3 disciplines like nursing and medics and anaesthetics. Primarily, the main areas were from anaesthetics, trauma, and surgery in general, so surgical teams, nurses within surgical departments, etc. So, study design-wise, there were 17 trials and 2 non-randomised trials, and then 21 group pre-test, post-test. Most papers reported outcomes at level 3, which is a simulated context, with some, about 4 papers, at level 4A, so a clinical outcome, a clinical measurement of the learners in a clinical context. No paper reported patient outcomes that were directly attributable to an SA intervention, which is quite hard to do if you think of the complexity of it. Only 4 papers of all of the papers included actually had a targeted situation awareness intervention. The remainder included SA as a broader part of a non-technical skills programme. And this is important because if you think about crisis resource management programmes and crew resource management programmes, we're targeting very complex skills, decision-making, communication, situation and awareness would be frequently included. And some of these programs are being run over, 6 hours. In fact, in our papers, two-thirds of the papers reported interventions of less than 4 hours, which really is very little time to try and consolidate this type of learning. Simulation-based learning using high-fidelity simulation was used as part or nearly all of the intervention in 31 papers, so nearly all of the papers use simulation to some degree. Theoretically, very few of the papers really had any sort of theoretical orientation as to how they expected this intervention to work, what their educational theory was, and what's more, what their situation awareness theory was, or crisis resource management. The majority measured SA using behavioural anchored scales, the most common one being the anaesthetics non-technical skills scale in about 50% of the paper. And those papers that had a targeted SA intervention all use situation awareness global assessment technique queries. So in terms of our risk of bias, if you just look at the bottom chart there, you will see that in terms of selection bias and performance bias, there was an unclear, or there was a reasonable risk of bias across the board, mainly because it wasn't described in the papers how these allocation was undertaken, how it was concealed, and how participants and personnel were blind. It was actually frequently impossible to ascertain if the author of the paper was also involved in the delivery of the programme, or involved in the assessment of the learners. In terms of the quality assessment, there was a reasonably good quality, 12.71 to 13.39, which is around about the same as a few other systematic reviews. But what we noted in it was that many papers didn't report on the specific reliability and validity of the instruments used. It was assumed that we would know. So in general then, simulation-based, we had 5 papers that compared simulation-based education to non-simulation-based education, 6 that compared different types of simulation, and 2 that had 4 that had non-simulation based interventions compared to other types of non-simulation based intervention. It's very difficult to say simulation based interventions. And then we had 2 miscellaneous papers. And in the narrative syntheses, basically the majority were simulation based intervention studies and 3 were non-simulation based intervention. So just as an example of one of our meta-analysis, this is a meta-analysis of the simulation based interventions as compared to other teaching modalities. And you can see from the forest plot there that the triangle is in favour of simulation-based education with a kind of moderate effect size of 0.61, but with statistically significant at 0.007. But it's important to say there was a heterogeneity of 42% in this particular meta-analysis, and there was a small number of papers. And when I took out the 4 papers then that specifically had an SA intervention, you can see that the effect size is down to 0.37. It's non-significant, but it is in favour of towards simulation-based education. So, in terms of the considerations that we've learned from this review, we would say there is a prevalence of research rationalising the use of simulation as distinct from research seeking to understand how it works and why it works in specific conditions. And that is in common with the work of Cook et al., who've done a lot of work around, or systematic reviews around simulation-based learning in general. There was very limited theoretically driven interventions, which we think is problematic for the interpretation of results. There was limited descriptions of the interventions, which is also problematic. In terms of crisis resource management programs, many papers reported effects on other non-technical skills, such as communication, but not on situation awareness, which would make you think, is it something about the program itself that's not targeting SA? There were several challenges encountered using behavioural marker systems, which some of the IRRs were very, very poor, less than 0.35 in 2 papers. And it is noted that only 8 papers reported a reliability statistic of these markers scales for the SA category. We also had to exclude a large number of papers who included SA as part of their intervention but did not report an SA outcome. They just reported an overall outcome. Thank you. So our conclusions, number 1, we acknowledge the heterogeneity and the limitations of the study that we've done. We couldn't undertake a publication bias because we didn't have enough papers for that, but there were some negative outcomes reported. Our narrative synthesis was broadly aligned to the quantitative findings, and we conclude that while constrained by these factors, simulation-based education can enhance SA as compared better, I suppose, than other alternative interventions. But however, we have no knowledge really as to what the most effective means of employing SA is, or employing simulation is. So we recommend interventions grounded in theory, possibly with a focus on mastery or proficiency-based learning, and also that we use reporting guidelines when we're reporting our work, such as those published by Cheng et al. In 2016. Thank you very much.